And the reason for that is Marc Riedl is flown up here to cold Seattle from San Diego. And thank you very much for doing so. And he's going to give us a presentation today on CVID-Associated complications. Marc, thanks for coming.
Good morning, and thanks very much for the invitation to join you again. I was here a few years ago talking about angioedema, which is the other hat I wear, but I do direct the Adult Immunodeficiency Center at the University of California, San Diego, and so one of my jobs is to see these patients and sort of direct their management. I realized giving this talk is a little bit like bringing sand to the beach, because you all have your own world experts on primary immunodeficiencies here in Seattle, but nevertheless, I'm going to try to give you a sort of a practical overview of assessing these patients and managing them, and maybe a review for many of you that have at least trained here at Seattle Children's. But hopefully you'll pick up something new and interesting, and we'll have time for questions at the end. And this is La Jolla Shores, which is about 3 miles from our office. I don't actually get there very often during the week, but it's not a bad place to spend a few hours. So here's my disclosures. I have done some research and advising with some of the companies that make immunoglobulin products. I don't think that'll influence what I tell you, but if you feel otherwise, please let me know. So I'd like to just review the symptoms that we see in the clinical presentation of CVID. And actually, we'll touch on, of course, the infectious complications, but most of my talk is not going to be about infections, because I think we need to understand the other potential complications of common variable that are due to the immune dysregulation that's part of the syndrome. And then we'll talk, as we hit on the different clinical presentations, we'll talk a little bit about management, although, as most of you know, this is a work in progress on how to best manage these complications that we see in these patients. So I'll draw your attention as we start out to this journal article. It just came out at the end of last year, and this is the latest consensus document on CVID. You see the names of sort of the global leaders in this field. And I just want to review for a moment, this may be very simplistic for this group, but the consensus definition of CVID. And I say this because I see lots of referrals for primary immunodeficiency in adults. I review lots of cases in various settings. And I actually think, maybe not we, but people get this wrong a lot. I think CVID has become sort of this lump of diagnoses. And I think if we're talking about a syndrome and the complications associated with it, we need to get the diagnosis correct from the outset. So the definition, of course, is most people will have at least one of the characteristic clinical manifestations that I'm going to mention to you. So you know these, but these include infectious complications, autoimmune problems, gastrointestinal issues, granulomatous disease, and so forth. These individuals have low IgG on at least 2 measurements 3 weeks apart. Those are sort of the official recommendations from the experts now. And also the criteria that IgA or IgM must also be low. And then finally, that there's an impaired response to vaccine challenge, which hopefully you're familiar with doing this, getting pre and post vaccine titers. And finally, that other causes of hypogammaglobulinemia have been excluded. So as we talk about quickly the differential diagnosis, this is sort of immunology for idiots, if you will. I'm not going to belabor this for this audience, but of course CVID is, we think, mostly related to B-cell problems, to antibody production. Increasingly, however, we're recognizing that it's not quite that simple. So you're probably aware that 30 to 40% of these individuals do have T-cell defects if you look at the function of those T-cells. And in fact, there's now emerging evidence that there are signaling problems with toll-like receptors and some of the innate immune system that go into the complexity of dysregulation with CVID. But for the most part, we focus, of course, on antibody issues because we have ways to address that therapeutically. And just again, the primer, very simplistically, to remind you that, of course, we replace immunoglobulin G, which is important for guarding tissue spaces, but we recognize that IgM and or IgA are low. I like this, that IgE keeps allergists employed, and I do see allergy patients, so that's important that we we understand IgE. IgD, we're not so sure what it does. It probably has important signaling properties, but we're still working on understanding the role of IgD. And then if we look, I'm not going to talk a lot about the underlying cause at a molecular level. We'll touch on it a bit, but honestly, we don't understand in the vast majority of cases where the problem lies specifically in common variable. We know that if you look at B-cell maturation, that it's really down here in the late stages that there seems to be a breakdown for patients with common variable immunodeficiency, and we'll talk a bit about that. You can actually measure with flow cytometry the stages of B-cell maturation, and that may tell us something about the phenotype or the complications that are going to occur in these patients. But of course, we recognize things can go wrong at several stages within B-cell development, and we see early problems in some of the combined immunodeficiencies. Here's where XLA breaks down before the pre-B-cell development. But here's the issue. For most cases, we believe of CVID is that it's a lack of plasma cell maturation and therefore antibody production. So I just want to say a few words about other causes because these are missed, and I get referrals on a monthly basis where they've been labeled with a primary immunodeficiency, but in fact there's other causes. So particularly for the fellows, it's important to sort of run the list in your head when you see these patients for evaluation and ensure that there's not a secondary cause for immunodeficiency, particularly in adults who often have other medical problems or a long list of medications. So I won't belabor this, but of course if you're losing protein somewhere, whether that's through the GI tract or the kidney, you can have hypogammaglobulinemia. Here's a laundry list of medications that we know can cause hypogam, and I hear people say a lot, well, corticosteroids don't cause hypogammaglobulinemia. That's not true. They do and they can, and that's been well documented. It usually takes higher doses for months at a time, so it's not going to be your asthma patient that takes prednisone a couple times a year. But certainly as we see more severe autoimmune problems and corticosteroids used for other reasons, that certainly is on the list. I've starred some of the other immunosuppressives that we see more commonly, at least in our practice, causing this. In the transplant literature, there's fairly good evidence that mycophenolate in combination with other drugs seems to induce hypogam in some patients. And then, of course, our friend rituximab, which is being used more and more for various conditions. We know from some data now that up to 40% of patients will get hypogammaglobulinemia with rituximab use. They don't all require treatment, and at least the published data suggests that probably less than 20% of people with this sort of secondary immunodeficiency actually get into real infectious problems and require treatment. But certainly those are people that we often monitor clinically because their IgG levels are in fact quite low. And then on the right side of the slide are drugs we don't see much anymore, but imatinib or Gleevec does show up, rare cause, but as we see more patients using that medication, something to be aware of on the differential. I throw the anticonvulsants here just because this is one people miss sometimes. Don't forget there are cases of pretty profound hypogam being described with the anticonvulsant medications. So in our patients that have seizure disorders or these used for other reasons, be aware of that. And I'll be honest, I don't even know what some of these drugs on the right side are. They keep coming up with new anticonvulsants. But it's interesting that it seems to be some class effect, and these are various classes of pharmacologic agents. But if you look at all the different anticonvulsants, there are case reports, at least, of these causing hypogam in adult patients. And finally, if we talk about adults, we have to be aware of malignancy. So you all know that CLL, multiple myeloma, these can cause hypogammaglobulinemia, and also the fact that infection is a very strong part of mortality in these conditions. So don't forget this when you're doing your evaluation. If there's reasons to be suspicious, either based on age or other symptoms, do the evaluation for malignancy causes, and we often have to work with our hemonc colleagues to sort of approach this in a rational fashion. All right, so all that said then, we do certainly have patients that fit the bill for CVID, and as you well know, this is the most common form of severe antibody deficiency, meaning one that requires treatment. Selective IgA deficiency is more common, but most of those patients are healthy and don't have infectious issues. We don't know the true prevalence, but you see the estimates there. I think 1 in 50,000 is a pretty reasonable ballpark, and we've talked about the actual definition in terms of what you see in the laboratories. I actually like this definition. Maybe I lived in Los Angeles for too long around Hollywood because it's like a movie, teaser. But the immune system in chaos, and this comes from Srini Kaveri, who's in Paris, a prominent immunologist. I think this is absolutely right. The more we learn about CVID, the more we understand that this is not just an antibody deficiency, but rather a network of immune dysfunction, and that probably explains the various clinical manifestations that we're going to talk about here shortly. So this is, as we've discussed, a failure of B cells to produce antibody. Now, I mentioned that in the vast majority of cases, we don't know where the molecular defect lies. And so when I was a fellow, we learned that probably only about 10% of patients have an identifiable molecular defect. I will tell you that that paper I just showed you that came out at the end of last year, looking at the latest data, suggests that probably less than 5% of patients actually have an identifiable mutation. So if you want to be a pessimist, we're actually losing ground. We're actually not understanding this very well. And part of that is because these are monogenic causes, these particular lists that you see here. And it's probably overly simplistic to think that CVID as a group is a monogenic problem. It's probably a variety of factors that go into the phenotype or the clinical syndrome that we see. At any rate, it's worth knowing these, particularly for the boards, but also for ongoing research. And I know that your group here at Children's does a lot of at least banking of samples because there's a lot of interest in looking at this more closely and identifying other molecular causes for CVID. We do know that most cases are sporadic, probably only about 10 to 15% of cases are familial. That doesn't mean we necessarily know the underlying molecular cause, but that you can trace it down in the family tree, that it does seem to be a familial trait. You're not supposed to be able to read this. This was actually supposed to be a little more encouraging because the list that I just showed you is here at the top, and in fact, in the last few years, we've added to that list. We've almost doubled the number of molecular defects that have now been sort of sequenced and identified as causing at least a CVID-like picture. So the expectation is that this list will grow, and I sort of joke that medicine is increasingly becoming alphabet soup, right? You have to sort of know the molecular defects, and it's hard to commit all these to memory, but with genomics, this is going to be the wave of the future, is sort of cataloging the various problems that can be identified through this sort of testing. Some of the other diagnostics that may be useful to us, besides the basics that we've covered, include looking at these switched memory B cells. And so, of course, this is basic flow cytometry. You can actually sort out the cells that are switched using markers such as CD27, CD19, and then actually looking to see which B cells have switched from an IgD positive expression to IgD negative, the class switching that they undergo. This is a particular study that sort of showed the potential value of this sort of analysis. And these patients were actually sorted. You see the healthy donors at the top, but sorted into groups with decreasing levels of switched memory B cells. So A, B, and C, with C having the fewest switched memory B cells of the group. I'm sorry, actually that's backwards.
There is a pointer, I think, up there. Drew, is it?
I think I have to use the arrow, right? But at any rate, sorry, these are actually the lack of switched memory B cells. And so what you can see